Hello, I'm Dr. Tim Mork, and I'd like to invite you to join me in viewing a short video that shares some of the highlights from a workshop entitled Workshop on Medical Foods, Science, Regulations, and Practical Aspects. It was co-sponsored by the Healthcare Nutrition Council and the American Society for Nutrition and held in Washington, D.C. on August 13th to 14th, 2019. The full proceedings are printed in the January 1st, 2021 issue of the open access journal, Current Developments in Nutrition, and can be viewed at the website shown on the screen. In the opening session, I gave an overview of medical food regulations, including how the U.S. Food and Drug Administration developed a regulatory definition that medical foods are intended for the dietary management of a patient with a disease or condition that imposes distinctive nutritional requirements that differ from the general population, and also that cannot be met by simply modifying the normal diet alone. Furthermore, medical foods are to be used under medical supervision. These topics were covered in greater detail throughout the conference. Here's an excerpt of that talk providing a brief history of how medical foods were defined by Congress in 1988 as part of the amendments to the Orphan Drug Act.
And then in '88, the Orphan Drug Act amendments created and defined a category of medical foods for the first time, separate from drugs, associated with the disease, but still falling under the food side of FDA, not the drug side.
Dr. Juan Ochoa Gautier gave a surgeon's perspective on how tissue trauma or surgery creates a higher than normal distinctive nutritional requirement for the essential amino acid arginine. Low blood arginine levels can result in significant impact on certain health outcomes for patients following surgery if not corrected by medical food intervention.
So I'm going to repeat, what are the clinical manifestations associated with low arginine levels? First one is immune dysfunction, and it's well described in the literature by us and by many other groups. In surgery, it increases the risk of infection, and there's a direct correlation between low arginine levels and T-cell dysfunction. In cancer, it worsens clinical outcomes. So far, according to Vincenzo Bronte, there are no physiologic states of arginine deficiency in cancer, and every time that it has been measured, the presence of MDSCs directly correlates with poor clinical outcomes in different types of cancers. And it may or may not be related to resistance to immunotherapy. The jury is still out on that. The other effect, which is really important because it's an immediate effect in our surgical patients, and we see it in the operating room, is that of impaired blood flow, and is a significant cause of ischemia. And ischemia leads to necrosis and breakdown of the surgical anastomosis. So if you take your colon and we take it, cut a piece out and put it back together, that place where we put the hookup together is called an anastomosis. The risk of breakdown currently in the literature is somewhere around 4% to about 18%. If you break that down, that's a devastating problem associated with high morbidity and high mortality. The surgical anastomosis depends almost exclusively on the amount of oxygen that reaches it for it to heal. So when you get ischemic, when you have poor blood flow, you have an increased risk of surgical breakdown.
Jessica O'Connell points out some of the differences in terminology between the statutory definition included in the law passed by Congress and the regulatory definition that governs manufacturers issued by the Food and Drug Administration. Dr. David Cockrum followed with practical definition of the term MODA, or modification of the diet alone.
These are a few differences. These aren't all the differences, obviously, but a few key concepts that I always think about as different. One is the statute talks about dietary management of a disease or condition, and the regulation talks about dietary management of a patient. And so from a starting point, those are two different approaches to what the dietary management is. Like I said, the statute distinctive nutritional requirement and the regulation unique nutrient needs. FDA since then has said that they should have used the word distinctive there instead of unique. And so that was a footnote, I think, in the ANPRM, but there's still, I think, a nutritional requirement versus nutrient need or two different two different phrases that I think could have broadly different interpretations. And then the third concept here, where there's a notable difference, like I said, is this mention of dietary modification alone.
So, thinking about what the dictionary would say about what does modification of diet alone mean, modification is either a limited change in something or also the result of such a change. A diet, pretty straightforward. It's things you habitually eat or drink, or, also it can mean a therapeutic diet, and alone, solely or exclusively or without aid or support. So I guess the way I would interpret what MODA probably should mean is it's a limited change in what one normally eats that reasonably can be accomplished by modifying what one eats. Makes sense?
Dr. Osama Hamdi shares how diabetes-specific formulations used in hospital dietary management of patients with diabetes are highly endorsed by the American Diabetes Association, as well as the European Society for Parenteral and Enteral Nutrition, ESPEN.
Now, if you look to American Diabetes Association, after this study and others in 2018, they said that enteral nutrition therapy with diabetes-specific formula appear to be superior to standard formula in controlling postprandial glucose, A1C, and as Susan mentioned, insulin reuse is much less. Again, ESPEN said exactly the same, based on the evidence that we have, diabetes-specific formula for patients with obesity and diabetes is recommended. So this is very obvious that if you give the right medical food for patients with diabetes during the hospital stay, which is the biggest cost of the disease, you can reduce the cost significantly and the length of stay, and endorse it by the biggest societies.
A patient's perspective on how medical foods can be effective in meeting specific nutritional challenges for patients with inflammatory bowel diseases, such as Crohn's disease and ulcerative colitis, was presented by Laura Wingate.
Patients are looking for treatments that lead to positive outcomes. So it's not just about reducing the inflammation and mucosal healing. They also want to know that they're not going to have that urgency, that there's going to be changes to their symptom experience. And they're really looking to find therapies that do not have life-threatening side effects. Enteral therapy, in particular, has been very effective in the management of pediatric Crohn's disease, and it's been shown to induce and retain a remission in the pediatric IBD community. And the parents consider the side effects less threatening than other therapies. And enteral therapy, particularly in pediatrics, has been used as a steroid-sparing agent. So we're able to put pediatric patients, particularly Crohn's disease pediatric patients, on enteral therapy, sometimes partial enteral therapy, and keep them in remission for long periods of time. Our problem here is often that's not covered.
Dr. Peggy Gunter presented the American Society for Parenteral and Enteral Nutrition's Aspen Value Project that modeled improvement in multiple health economic outcome indices for patients in several therapeutic areas when targeted nutritional therapies were studied.
This is sort of a schematic of this using the 5% Medicare claims data. We limited to the patients who had all of these diagnoses, diagnostic codes, so the ARDS patients were in the hospital, they had sepsis, they had enteral nutrition. Then we applied the number who would have had a decreased length of stay, meaning that you're modeling against all of the patients who had enteral nutrition. We changed it into how many patients per month. We then multiplied it by 12 to annualize that, and then you take the final total, which was $23,000 per case, annualize it to about $2.58 million per year, and then you multiply that by 20, because remember, this is a 5% Medicare sample. So in this particular study, we were able to show that if all the patients who received enteral nutrition had received this particular advanced nutrition formula, Medicare would have saved about $52 million per year.
In the closing session on the second day, panelists were asked to list one hurdle to patients getting new products to help nutritionally manage their disease, and one possible step forward to overcome such barriers. Dr. Gunter highlighted one ongoing challenge is the need for clarity around the distinctive nutritional requirement, or DNR, criteria for medical foods.
It seems to me, just coming in and hearing everyone, I think it's this distinctive nutrition requirements that seems to be something that we're spending so much energy trying to address. And I'm not sure in my lifetime or my children's lifetime that we're ever going to get to being able to really point out those in very complex patients who have perhaps multiple requirements. So I think that's something that when I list, well, we'll get to that later, but with that, it's the issue of drug versus food and the FDA's perception of any kind of claim related to disease as we're shifting into drug. And the whole thing about needing an IND for research, and that's just taken us right down that drug road that I don't think anyone wants to go down.
Okay, see if I can capture this correctly. Having a clearer understanding of DNR and recognizing that that could be multiple, it could be individual requirements, but just the DNR construct itself is in need of better definition and understanding. Is that the first one? And then the other one is, along with that, how do you differentiate between foods and drugs in the management of disease?
In closing, Dr. Barbara Schneeman, formerly with FDA herself, suggested a possible way forward could be urging FDA to develop a guidance document with a clearer definition of key terms discussed in this workshop, and similar to guidance issued for dietary supplements.
Great. So I talked about science, and I think a practical thing to consider is developing a guidance document. I mean, that's what FDA does when it's going to use science for health claims or educate the industry about what might it look for. Develop a guidance document, and the dietary supplement structure function health claim or structure function claim guidance document could be a useful example because it talks about what's needed, but then it also gives practical examples. You want to say this about your product, this is the kind of evidence that could work or not work. So that's a very detail-oriented thing that could be useful. And with thinking about how do you validate the science, then where does it get used? Does it get used in medical nutrition therapy? Does it get used in clinical guidelines? Are those ways we can think about how we validate the scientific support for a particular product?
For all of you watching this short video, I hope you'll check out the full proceedings of the day-and-a-half conference. The link is shown below to get a fuller picture of the detailed criteria that FDA applies to the medical food category and how researchers, clinicians, industry, and patient groups are all striving to develop and commercialize innovative medical food solutions that benefit patients having unique nutritional needs. Thank you.